Hello, this is going to be a short presentation about induction of labour, specifically thinking about the transcervical catheter or Foley's catheter. There'll be a little bit of background about induction, why we do induction, the aim of induction, some of the different methods that we use here in Swift, and then specifically thinking about the method of Foley's catheter insertion, followed by a short video clip. So as we all know, induction is an intervention where we're trying to encourage labour, culminating in the birth of baby. And this is through progressive dilatation of the cervix and initiation of uterine contractions. We do induction for a variety of reasons when the risks for either the mother or the fetus are higher if the baby is left in utero compared to the process of induction and delivery. There are some contraindications for induction, as we know, so specifically major placenta previa, any abnormal lie, particularly transverse lie, if the woman has had a previous uterine rupture or a classical caesarean section, or they have had 2 or more previous caesarean sections. Previous caesarean section we're also cautious about with induction due to the risk of uterine rupture. We also need to be aware about the fetal condition, and if there are any signs of fetal compromise, we will think carefully about whether induction is appropriate and how we will carry this out. And multiparous women, so particularly women with a parity of 5 or above, have an increased risk of hypersensitivity to prostaglandins, and so we have to be cautious about the method of induction that we use. So the methods of induction that we use commonly here in Swift, we use prostin and propes if required. We're also very comfortable with ARM and oxytocin. We use misoprostol for women that have sadly had an IUD. And for mechanical dilatation of the cervix, we're moving to using Foley's catheter along with Dilapan. So the Foley's catheter or transcervical catheter aims through mechanical dilatation of the cervix to help soften and dilate the cervix by applying pressure to the internal cervical os, and indirectly by increasing secretion of prostaglandins from the fetal membranes. It should be considered when the woman is being induced with a Bishop's score of 6 or less, and if pharmacological methods are unsuitable, or they're being induced in the outpatient setting, or the woman's preference. So they can be used very successfully in women with previous lower segment caesarean section, and this is because they have no increased risk of uterine rupture. They can also be used in women that have had an IUD, and this can be if prostaglandins are contraindicated or they have had the complete course of misoprostol and unfortunately it hasn't been successful and we're still aiming for a vaginal delivery. Grand multiparous women, so again, para 5 or above, that we can't ARM initially, a Foley's is a great option to try and get to the stage where we're able to ARM them. If a woman has had previous hyperstimulation within this pregnancy or previous pregnancies, and we want to avoid using prostaglandins, again, the Foley's can be really useful for this. And in the outpatient setting, then they are our induction method of choice. The only real contraindication for avoiding using the Foley's catheter is if there is an increased risk of infection, and so if there is any history of rupture of the membranes or any infection within the vagina, we should avoid using the Foley's. Similarly, if there's any vaginal bleeding, we've already talked about the contraindication for placenta previa or malpresentation and how we be careful about whether we choose induction if there are any signs of fetal distress. So moving on now to talk about the methods for insertion of the Foley's. So I'll briefly talk through this with this slide, and then they'll follow a short video clip which hopefully will show you that it's an easy technique, and I hope that with some of the I hope that you'll be able to feel confident inserting it. So generally this is done with the woman in the lithotomy position, ideally under aseptic conditions, and it can either be done using a speculum or with digital insertion. So if using the speculum, the Foley's catheter is usually grasped with sponge forceps. We visualize the cervix, push the Foley's catheter through the external os, moving through the internal os, and remembering that the cervix is roughly kind of 4 to 5 centimeters in length. So we want to insert at least 5 centimeters of the catheter. And then inflating the balloon using 30 mils of sterile water or saline. Once it's inflated, we would pull the catheter down gently, so it's against the internal os, and then put a spigot in the end so that no blood or mucus will leak out of the catheter. We can then take that gently to the patient's leg, just to avoid it dangling down and causing any irritation. If we are inserting it digitally, we're just doing it by feel, and so you wouldn't need to use a speculum. The catheter will remain in place for between 12 and 24 hours. Within our guideline, you'll see that we're aiming for removal between 18 and 23 hours. And removal is easy, just deflate the balloon and then pull out, so we don't need to repeat the speculum examination. It's useful to ensure that it is properly inserted, and we do this by, if you haven't visualized the cervix, then you can do a gentle digital examination afterwards. But you'll find that if the balloon is inflated within the cervix, as you gently pull down on the catheter, it will come out. And so all you need to do then is deflate the balloon and then try and reinsert it. Okay, so a short video clip will follow, which hopefully will help when it comes to insertion. Thank you.
Cervical ripening is achieved by using a transcervical balloon catheter, which works by applying mechanical pressure on the cervical canal. The balloon also lifts the fetal membranes, triggering the release of endogenous prostaglandin. This process usually results in softening and cervical dilation, with less of an effect on effacement. Mechanical ripening is associated with the lowest chance of uterine tachysystole and/or fetal heart rate change during cervical ripening. Mechanical ripening is equally effective to achieving vaginal delivery as hormonal methods of cervical ripening. Cervical balloons can be placed either with the use of a speculum or through digital guidance. A speculum is inserted, and the cervix visualized. The cervix may be cleansed with betadine solution for a septic technique. Forceps are used to thread the deflated end of an 18 French Foley balloon catheter through the internal os. The balloon is inflated with 30 to 60 milliliters of sterile saline. Following correct placement and inflation, the balloon is then pulled back to apply constant pressure to the internal os. The speculum is removed, and a bimanual examination is carried out to confirm that the balloon catheter is correctly located beyond the internal os and not within the cervical canal or intravaginally. The volume of saline used for inflation is documented. Alternatively, 2 fingers are used to guide the deflated tip of the balloon catheter through the internal os. The balloon is inflated, and bimanual examination is carried out. This technique can be easier when the cervix is slightly dilated. Typically, the balloon catheter is occluded with a cord clamp to prevent leakage, and the catheter is taped to the patient's thigh to maintain moderate tension.